All right, we are live.
All right, good morning, everyone. This is a joint meeting between House Healthcare and Senate Health and Welfare Committees. Welcome. We're continuing our work on COVID-19 and looking to see what is in place, what needs improvement. And today we're inviting folks in to talk about some of the issues that we have learned about during our testimony. Before we start, I'd just like to say welcome everyone to Earth Day. And when we're in the middle of a public health crisis, I think it's really instructive about how important it is to care for our environment, because as we care for environment, we care for ourselves. And that is what we are all about in these two committees. So we have invited Addie Stromolo from the Agency of Human Services to give us an update on what's going on with our health exchange enrollment. And so Addie, you're here. I know you have limited time, and you are also going to testify on the migrant care issue from the DIVA perspective. So we'll give it to you. And as we go through, if there are questions of clarification, we'll ask them. Otherwise, we'll wait until you're finished with each topic.
Great. Thanks very much. For the record, this is Addie Stromolo, Deputy Commissioner at the Department of Vermont Health Access. Thank you for having me this morning. So I thought I would just walk through a quick update in terms of the enrollment that we've seen through the exchange, and then I can jump into the immigration issue. As I think you all know, we're expecting the majority of our enrollment due to the COVID-19 emergency and the related job loss to come in through Medicaid, as opposed to the qualified health plan door. So I'll just give a quick update in both areas. So far, we've put a number of flexibilities in place to facilitate enrollment into Medicaid. That includes waiving financial verifications, waiving renewals, and just accelerating the enrollment process in general. So far since March 20th, which is when we put those flexibilities in place, we've had about 5,000 households enroll. Just for context, that includes about 2,400 that were already in the pipeline when the emergency started. So they're not brand new to the system. So it's about 5,000, and then about 1,000 of those took advantage of those flexibilities that I described around financial verifications. So that's the Medicaid side. For those who are over income for Medicaid and otherwise do not have health insurance, we did open a special enrollment period. That also opened on March 20th. And we originally slotted it for a month. Last week, we decided to extend it for an additional month. So that is now ending on May 15th. The enrollment there has been somewhat limited but steady. So we have seen 237 households come in through the special enrollment period. Again, this is for people who attest to not having any other source of coverage. We've seen, I think it's been an average of around 10 households a day. And again, these are not all completely new to the system. Many of them are people who previously had qualified health plans that were later terminated for non-payment. So that's a quick enrollment update. Maybe I'll leave it at that and see if there are questions on that front before changing topics.
Yes, I think that's a good idea. When you're talking about those who were re-entering into the program as a result of non-payment, was there a payment forgiveness reason for that? How is it that they're coming back in at this point?
Yeah, the situation would be that someone terminated for not having paid their bill earlier in the year. And then in order to come in now, they're asked to pay the outstanding balance for this year. Okay. So that's what the process has looked like. Again, it's a subset of that group, but I just wanted to clarify that not everyone is brand new.
Okay, thank you. Questions?
Yes.
Bill, go ahead.
So good morning, Addie. I appreciate you joining us. And I guess I want to be clear that the open enrollment period has in fact been officially extended to May 15th. Is that what you said, or 17th?
May 15th, Friday.
May 15th. Yep. Has notification about that been made public? I have missed it if it has.
So DEVA put out a press release on it the Wednesday prior to the previous deadline. So that was Wednesday, the 14th of April.
Okay.
And
we
then,
talked about it in this committee with Mike Smith, kind of a little ahead of it, unfortunately.
right,
Making it
that's right.
official.
I think that was the official announcement.
Well, not everybody watches our YouTube channel.
Oh, wait, everybody does, everybody.
Everybody does, I see. But I think it might be important for us to be able to, as the Healthcare and Health and Welfare Committee, make sure all of our colleagues are aware of this. And so if that press release could be resent to us, to Nellie or Demis, and then we can in fact share it with our colleagues who will then in turn pass the information forward, I think that would be very helpful.
Sure thing. Yep, we'll make that happen.
Terrific, that's good. I will say that am I muted? Nope. I will say that our clerk of our committee, Senator Ingram, has been writing some very robust summaries of the work that we've done each week and sent those out to our full Senate. But it doesn't hurt to highlight this one because I think it's important for constituents who may want to enroll. Good. And I just want to say publicly, thank you, Senator Ingram, for that work. It's been really important. Anne-Marie, go ahead.
Hi. I think we heard early on that there was some testimony people had trouble getting through. Did you find that? And if so, was that rectified?
Yeah, so in terms of getting through to the exchange, we've actually, our calls have surprisingly been down, and Maximus, our vendor, has been able to meet service level agreements with regularity. There was one period of time when there was actually an individual in one of the Maximus offices that had tested positive, and they had to close down one of the sites where they function. So that did cause some slow response times, but that was several weeks ago now. And since then we've been, in the green, so to speak, in terms of being able to take calls.
Okay, thank you. Yeah, it was early on, I believe.
Okay. Any other questions?
If I could make a comment as well, that I think we would do well to remind our colleagues that eligibility for Medicaid is open at any time, so that when we talk about the extended open enrollment period, we should also clarify that folks who are impacted by the COVID-19 situation are eligible to inquire about eligibility for Medicaid at any time. Is that correct, Addie?
Yes, that is. And we've been trying to keep that simple message across the board. Give us a call. We'll
Right.
figure out what program you're eligible for.
Great, thank you.
Okay. The question are we using our integrated eligibility, our new electronic eligibility process yet or not? That's still in the works. It's still being developed. Yeah.
Yes, this is our existing
Yeah.
eligibility system.
Okay. All right. I had another question. I'll hold off for a little bit. Any other questions? Yes, Representative Cordes.
Thank you. Good morning. I have a couple questions. Are you able to trend out the data over a number of months? For example, the specifics like people who lost employer-sponsored health insurance that applied for Medicaid or are now on Vermont Health Connect, and the number of people over a number of months, not just the last few weeks, who qualify for different subsidies now, different CSRs and premium tax credits.
So in terms of prospective projection, I think what I can say is that we have looked at different studies that have come out. I don't think we've done our own projections, but we've seen a number of predictions about the number of people losing employer-sponsored coverage through their jobs and needing to come over into Medicaid. And those numbers have been quite high. We have not seen those yet here in Vermont. So for example, one national study predicted a loss of about, I think it was 70,000 people losing employer-sponsored coverage, which would translate into between 24 and 52,000 new Medicaid enrollments. At this point, as you've heard, we've seen 5,000 new. So we're not really on that scale, but I think there's an expectation that maybe there's a delay and that the volume will continue to increase as people who were able to stay on their job benefits come off. So that's a little bit anecdotal, but those are the kind of studies that we've seen. So we're making provisions to make sure that we can continue to handle the call volume, assuming it goes up. In terms of just like a trend line for people getting increased subsidies, one thing that we've looked at is the number of people reporting income losses in the QHP side, and that has, as expected, gone up quite a bit. We have a graph that I could share. Actually, I think that one's just a table, and it just has the raw numbers in terms of reported changes. But that is information that we'd be happy to share. Is that the kind of thing that you're looking for?
I'll answer for all of us. Yes, that would be extremely helpful. Thank you for that question.
Sure. So I can put together some illustrations of what we've seen in terms of it.
That's terrific. Representative Cordes, do you have another question? Are you all set?
I'm all set. Thank you very much.
All right. Any other questions? Representative Durfee, you have one.
Yes, thank you. And good morning. Eddie, I was just wondering for a little more context, the 237 households that have signed up through the open enrollment, not Medicaid, how that might compare with the typical number of new enrollments we would see during the standard open enrollment period.
Oh, I thought, yeah, okay, that's a good question. So it's a little hard to compare to the standard open enrollment period because during that time, everyone in the QHP market renews. So we see a lot of activity. But in terms of comparing it to kind of a normal course of business in the middle of the plan year, it's actually not very different because as I think I mentioned to your committee last time, there are a number of different qualifying events that can allow people to sign up for QHPs outside of open enrollment. And we do see a couple hundred of those a month. So it's actually not that inconsistent. For context, the 237 specifically came in through this special COVID-19 enrollment period that we opened up. We've seen an additional 200. So for a total of 417 QHP enrollments through other qualifying events since March 20th.
Good, thank you.
That's helpful, thank you. Any other questions? Just as a reminder, Addie, the eligibility determination for folks on Medicaid, if someone's income goes up, then they are, what is the timing and the frequency with which their eligibility is made? Do they have to report that increase in income and then become ineligible? How does that work?
There's a general standard to report changes that could impact your eligibility within 10 days. That is not something that is, actively enforced. But that is what the regulatory standard is. In general, it really comes up for your annual renewal in terms of checking what your current income is.
Okay, but
and those are on pause.
And right now, within the emergency, are we being less attentive to the 10-day changes?
I mean, I think I can say it's not a top enforcement priority ever for us. I think it's a little past, we make that requirement known through noticing and other vehicles like that. But yeah, we are doing everything we can to keep people on right now.
Good. All right. Thank you. Any other questions? Okay.
Representative Houghton has a question.
Oh, sorry, Laura.
That's
go
okay.
ahead.
Just a quick question, Addie, and I apologize. I think you've said this during the last testimony, but the $600 additional a week that people will be receiving through unemployment, does that factor into income Medicaid eligibility?
Great question. That does not. That amount is disregarded for Medicaid eligibility purposes. That was part of the Federal CARES Act. The complication is actually that it does count for advanced payment of the premium tax credit. So we do want to collect that information so that people are getting the right amount of subsidies on their QHP. But again, it doesn't count for Medicaid.
Thank you.
Okay, any other questions? All right, so why don't we move on? First, thank you very much for that update, and it would be helpful for you to send that data along when you have a chance, and then we can stay updated with what's happening. Why don't we move on to the migrant justice and healthcare issue, and Addie will ask you to provide us with your testimony.
Sure. Thanks again for.
I should say Deputy Commissioner Strumalo. Sorry.
No, please. Addie is fine. So what I was planning to do here was just walk through the eligibility standards for our healthcare programs with respect to immigration status. So let me know if that's kind of not what you were thinking. I was planning to just give the policy parameters for this population. Okay, I'll go ahead with that.
That's good. That's
okay.
Good.
I think the takeaway is that, on the undocumented side, I'm not sure that we have great news or a great option, but let me go through the policy. So for Medicaid, starting with Medicaid, undocumented immigrants are not eligible. It's a federal standard that we don't have much flexibility around. Legal immigrants are generally subject to a 5-year bar, which is to say that they can't enroll until they've been lawfully present for 5 years. There are exceptions to that, and particularly in Vermont, persons under 21 and pregnant women do not have to meet that 5-year standard, as well as legal immigrants with certain statuses like refugee statuses. So just to reiterate, federal law is quite strict on this, and there is not anything in the kind of recent legislation that softens it. The one area where there's some ability to provide coverage is that Medicaid can pay for emergency services on behalf of people who are not eligible for Medicaid solely based on their immigration status. So this is something that could include undocumented immigrants. And I just this is not the same as becoming eligible for Medicaid, but it's a mechanism for Medicaid to pay for certain services, and which one would assume that COVID treatment would be considered an emergency medical condition, meeting that standard. So in practice, that means that a hospital who treats an undocumented immigrant for COVID-19 on an emergency basis can seek reimbursement from Medicaid, and there is a process for that. So that's kind of the Medicaid summary. I will give the same summary for the commercial market, unless you want to pause there and ask and pose any questions.
Let's do that. Questions regarding Medicaid eligibility for Representative Cordes.
Regarding the emergency Medicaid, is there's I think a potential issue with the income eligibility in that workers and undocumented Vermonters with family that don't live in the United States cannot count their dependents if they live outside of the United States. So that causes a problem with their income eligibility. Is that correct? And is there something we can do in Vermont to help with that situation?
I'm gonna have to think about that. So the situation would be that this is someone who does meet the immigration eligibility standards, but then there's an income issue making them ineligible for Medicaid?
They are still eligible for emergency Medicaid, but the income requirements, I think, are around $17,000. And it causes a problem in that that $17,000, I believe, is attributed to that single person instead of being able to include their dependents if their dependents live outside of the US.
Okay, I apologize. I'm not very familiar with that scenario. So let me take that back and get you an answer.
Thank you.
Any other questions?
I have one, Madam Chair.
All right, go ahead, Senator Ingram.
Thank you. Eddie, do you have any idea what the numbers of people are in Vermont who, who are legal immigrants who are still waiting for their 5-year period qualification, or the numbers of people who are under, 21 and pregnant, or refugees who can apply? Just wondering how many people we're talking about here.
So I tried to see if I could get some data to provide today, and I don't have it yet. So I'm happy to report back on that. I will say that if someone hasn't met the 5-year bar, they would be denied. So we wouldn't necessarily be able to track that. I think what we could provide is the number of people on Medicaid who are in a certain immigration status.
Okay, great. That would be helpful when you get
Sure.
Terrific, good question. Yes, Senator Cummings.
Okay, Addie, I think it was testimony before this committee, but it might have been one of the emails I'm getting from Migrant Justice that said that Massachusetts and one other state had figured out how to put immigrants under Medicaid. Is that Senator Lyons is nodding, so it was testimony. Is that something you know anything about? Is it something we haven't done we might be able to do, or is it what we've already done?
Is this something that is recent and specific to COVID-19, or?
Yes.
So the thing that we're aware of is that there are several states who have expanded the definition of emergency medical condition, I think is the technical terminology, to include testing and screening for COVID. So not just treatment.
Okay.
So that would provide, a little more coverage in terms of Medicaid reimbursement for that population that's not eligible for Medicaid, but for their immigration status. So that's something we can definitely look at, and we are in the process of seeing kind of how other states have handled that. But it's a small piece. I'm not sure that we're hearing that people aren't able to access, testing because of their Medicaid status.
Okay, but it would be good if we could test before it spread to an entire population, which would hit farmers and
Their workers.
be a good thing to know. So if we could do that, that would be, I think, a good thing. Thank you.
Sure.
Thank you, Senator Cummings. That is something that we had wanted to ask about, and you remembered. I guess the question is the testing and screening, and would then that could fall under emergency rules for Medicaid. There wouldn't be anything that we would have to do legislatively. That's a question.
No, I don't think so. I think it would just be an interpretation of the definition of emergency medical condition.
Okay. All right. Will you keep us posted on any decisions?
Yes, definitely.
Good. All right. Any other questions?
So I just want to raise, this is Bill. I'm sorry. I see that Representative Rogers and Houghton have their hands up as well. So let them
We're
go
getting
first.
to them, but you got right there. So go
Okay.
ahead.
Well, is there anyone from DEVA who can monitor or listen to our further testimony today, so that questions, so that folks at DEVA can understand what some of the additional questions are that come up? Is that a possibility at all? I realize your time is very short, and I appreciate you being here.
No worries. Yes, I think that is possible. And while we keep talking, I will send a few texts to.
Okay.
Sure.
Because I think when we hear other testimony, it may raise more questions that we need to explore.
Sure.
Thank you.
Excellent. Representative Rogers.
Thank you. I have two questions. The first one, just to follow up on Senator Cummings' question, my understanding was that testing was not something that people should have a barrier to regardless of health insurance standard. Can you just confirm or clarify if that's correct?
That's my understanding too. I can't say that I have a ton of, we're obviously looking at it with a Medicaid specific lens, but we have not heard that there is a financial barrier to testing itself.
And then my second question is kind of about the logistics of emergency Medicaid. So it seems to me like the kind of the flow of how everything would work would be you would go to the hospital, you, the patient, would get billed, and then the hospital would see if they could get reimbursed from DIVA for emergency Medicaid for you, the patient. And I guess I'll pause there to see if that's generally the right flow.
Yeah, I think how it works is that after the treatment happens or the stabilization happens, then the hospital would work with the patient to see what insurance coverage they might have. And in going through that process and figuring out that they're not eligible for Medicaid, there would be a screening process that comes to us. We would deny and then review the treatment that was received and see if it counts as emergency treatment subject to reimbursement.
So I guess my concern then, just to name it, and if you have additional thoughts, I'd like to hear them. My concern would be that if someone is making the decision of whether or not to go to a hospital to get treated, and there's no way to know beforehand if they will qualify or to know with certainty that they will qualify for emergency Medicaid, like I understand that it's helpful to the hospitals to get reimbursed where they might not otherwise without this, but from a patient perspective, making a decision of whether or not to seek care, I'm wondering if there's, I guess, first of all, if people who might qualify for emergency Medicaid know that it exists. And then second of all, if there's any way to make people aware beforehand of whether or not they might be someone who would qualify.
Yeah, that's a great question. So I think what I can say is that when someone does come through the normal screening process for Medicaid and is denied based on their immigration status, or really it may not be specific to immigration status, the notice that they get will say you may be eligible for emergency coverage. So there is that communication. That said, to the extent that even applying for Medicaid might be a deterrent for this population, I'm not sure that we have any great answers to that. But if someone is willing to kind of come into the door, see if they qualify, there is communication that happens at that stage.
So I'm gonna interject at this point. I know Julie Doucette had her hand up and she's going to be testifying in just a bit. Julie, will this information that you wanted to respond to, will this be incorporated in your testimony? No, it won't. So let's let Julie say, Julia, is it Julia or Julie? Because Julia, got it. Why don't you offer a comment at this point, and then we'll go on to Representative Houghton and Senator McCormick. And you are muted.
Thank you. I just wanted to say the Department of Health in Vermont covers all COVID testing. So anyone, regardless of insurance status, is covered for the testing part of it, regardless of insurance status.
Okay, so the screening piece then, testing, screening, treatment, those are the three areas, but testing is covered by DOH. Okay, Representative Houghton, you have a question.
I'm okay, thank you.
All right, good. Senator McCormick.
Julia just answered my question.
Perfect.
So I'm good.
Any other questions? I think, Addie, you're getting to be overtime, but we appreciate the time. Any other questions from folks? All right. Thank you. Thank you very much. And
thank you for joining us.
Yes. Keep us posted on, you've heard the questions. If you can get some answers to those, that would be helpful. And some have already been answered. So.
Yeah, I think I have 3 takeaways and I will definitely get back to you all on them.
Terrific.
Okay. And I would like to ask you to express our appreciation from at least our, and I'm sure from both of our committees, for the decision to extend open enrollment for the exchange as well, which I know was a question, but we appreciate that the effort to incorporate that at this time. Thank you.
Thank you. Thanks
All
for
right.
having me.
Terrific. So we'll move on to our next person is Will Lembeck of Migrant Justice, and you are here. I saw you. There you are. Thank you for being here. And do we have anything on did you submit any testimony to us, Will?
No, Senator, there's no written testimony submitted.
Okay, all right, we're good then. So why don't you go ahead and provide your testimony?
Yeah, thank you. And as it was communicated in the staff, part of the testimony will be given by a farm worker, Jose Ignacio. I just asked him to join now. So who's ever administering should see him come in a second, and his name will be Jose Ignacio.
Bueno.
So I'll be doing some consecutive interpreting for his testimony, and then I'll have some remarks to add as well. And my apologies for joining a little bit late.
You're fine.
Thank you. So while we wait for Jose Ignacio, for those who don't know, Migrant Justice is a Vermont-based organization founded and led by immigrant farm workers in the state of Vermont, primarily people working in the state's dairy industry. It's a human rights organization that's been in existence for the last 10 years. And is no stranger to the State House, has been involved in a number of legislative initiatives around driver's licenses, policing policy, Department of Labor, and labor conditions, as well as working to improve farm conditions by working with employers and with dairy corporations. And with that, I see José-san. Hola, Nacho, ¿cómo estás?
Hola, muy bien.
Entonces, bienvenido. Este es el comité de salud. ¿Tú puedes ver las demás caras ahí?
Sí.
Ok, pues sí, dale, man, y yo te puedo traducir.
¿Sí me escuchas? Okay. Hola, mi nombre es José Ignacio de la Cruz. Soy trabajador de los ranchos lecheros del estado de Vermont.
Hi, my name is Jose Ignacio de la Cruz. I'm a dairy worker in the state of Vermont.
Okay. Quisiera compartirles un poco de lo que está sucediendo en los ranchos ahora. Seguimos trabajando en esta cuarentena. No hay descansos para nosotros. Seguimos llevando el sustento de la comida a las mesas.
Oh, connection's going.
Nacho, quizás si apagas tu video ayudará con la conexión. Tenemos un poco de problema en escucharte. I just recommended that turn off his video to save bandwidth. Escuchamos que siguen trabajando para traer comida a la mesa.
Sí, ¿sí me escuchas ahora?
Sí, mejor, gracias.
Ok, sí, les quería comentar un poco del trabajo que estamos haciendo aquí en el estado de Vermont. Seguimos trabajando para llevar el sustento a la mesa. Para nosotros no hay cuarentena, seguimos trabajando todos los días. Y sí, compartirles un poco de la situación. Nosotros en las casas que estamos viviendo demasiadas personas en algunas casas de 5 a 7 personas que tienen más de 20 trabajadores, y pues no podemos respetar la cuarentena de 6 pies, la distancia. Entonces también no tenemos recursos como mascarillas y guantes. Ahora el patrón está pidiendo que un par de guantes se ocupe para 2 ordeños, para 2 tiempos, porque él dice que habla con las personas que le surten los guantes y mascarillas, y esas personas le están diciendo que no tienen ya más mascarillas, prácticamente con que no hay los recursos para proteger.
Sí, sí, pero
¿Me escuchas bien,
permíteme.
güey?
Sí, sí, te escucho, pero te voy a traducir. So I want to share with you a little bit about what's happening on dairy farms across the state right now. As much of the state is under this stay-at-home order, we continue working. There's no rest for our community, no quarantine for our community, because we're working every day to bring food to the table. And I want to talk with you a little bit about the situation in our housing, in our homes. We have too many people living in housing. Simply put, we see 5 to 7 people sharing small homes, small trailers together, and so it's impossible to respect the social distancing guidelines of staying 6 feet apart. It's not realistic. And on the farms, we don't have masks, we don't have gloves. On our farm, the farmer just told us that we need to make 1 pair of gloves last for 2 milking shifts, which is very difficult to do. And he says that he spoke with the people where he buys the masks and gloves from, and they just say that there aren't any more, that we have to make last what there is. Sigue, Nacho.
Ok. Para nosotros es muy peligroso y tenemos demasiado miedo seguir trabajando así, pero pues sabemos que ahora es esencial nuestro trabajo y también nos llaman trabajadores esenciales, pero somos excluidos de todo tipo de apoyo. Nos excluyeron del apoyo de los 1,200 y tampoco podemos aplicar para el fondo de trabajo. De cuando estás sin trabajo también no podemos aplicar sobre eso porque igual no tenemos un seguro. Entonces, sí, también creo que esta es una situación, una crisis de salud pública, y también si alguien se enferma, es imposible no enfermarse también los demás compañeros porque somos demasiadas personas en las casas, entonces no podemos hacer eso. Y sobre la salud, también creo que es un derecho, tenemos el derecho a la salud gratuita, todos, no importa de dónde eres o quién eres. Solamente queremos que nos traten como trabajadores igual de aquí del estado de Vermont. Y sí queremos pedir el derecho al acceso a la salud gratuita, porque si te enfermas, también tienes que pagar de tu bolsa todos los gastos médicos.
For us, this is a very dangerous situation, and there's a lot of fear in our community to have to continue working under these conditions. But we know that our work is essential, and we know that right now the government is calling us essential workers. But despite being called that, we're being excluded from necessary supports. Our community has been excluded from the $1,200 relief checks. We can't apply for unemployment insurance. If I had to leave work, I wouldn't be able to get unemployment because of a lack of social security number. But we're in a public health crisis. And if one person gets sick, it's impossible for others not to get sick. And for us, with too many people in houses, that's a real concern. And now regarding the health situation, we believe that healthcare should be a right. It should be free of charge. It doesn't matter who you are or where you're from. And so what we're asking is to be treated the same as other workers in the state. And we're asking that our right to healthcare without having to pay be respected, because right now, if I get sick, I would have to pay out of pocket, and I don't have the money to pay for those services. Sigue, Nacho.
Okay. Estamos pidiendo que nos den sí el apoyo del estado de Vermont para que podamos salir adelante y que nos ayuden ellos que tienen la capacidad de poner este fondo que van a recibir y que nos toque apoyar a la comunidad migrante, porque otros estados lo están haciendo y creo que Vermont también puede hacerlo, y que también al hacerlo que no pongan demasiados obstáculos para recibir el apoyo, porque para nosotros es muy difícil conseguir las pruebas de que lo que necesitamos, porque no podemos salir tampoco a las tiendas a comprarlo, y igual por el miedo de la migración que sigue arrestando a compas. Hace 3 o 4 semanas arrestaron a un compa que fue a la tienda, a la Walmart. Entonces siguen los arrestos también. Ellos están publicando que están parando los arrestos, pero no es cierto, siguen los arrestos contra nosotros. Y creo que en esta etapa que estamos debe de parar todo eso para que nosotros podamos seguir trabajando y poder seguir ayudando al Estado también. También que sea un acceso al programa que sea más fácil para recibir nosotros ese apoyo.
So we're asking to have support from Vermont in this moment of crisis, that we respond together as a state, because the state has the capacity, it has the resources to include the immigrant community. And we know that other states are doing it. And so Vermont can do it too. And we also think it's important that if this treatment coverage is expanded, that it not be tied to too many requirements or restrictions, because as a community, it's hard for us to get the proper paperwork and documentation to prove different things like income and others. And it's hard for us even to get out to the store, let alone get these types of documents. And on that note, the fear of immigration continues to be present. Just a couple weeks ago, somebody in Vermont was arrested as he went to the Walmart to go shopping. So immigration agencies are saying that they're suspending their activities, but that's just not true. They continue to arrest us, and that means that we have to continue to have fear every time we go out. So I think it's important that the state supports immigrants so that we can continue working and continue supporting the state as well. And that through the expansion of this Medicaid program, it can include immigrants to receive the support that we need. ¿Algo más, Nacho?
Ok, sí que Vermont debe de usar el fondo de emergencia de medicina para cubrir la comunidad migrante, que sin trabajadores saludables no hay comida. Sí, pues recargando lo que necesitamos el apoyo de todos ellos para que podamos seguir trabajando y podamos llevar la comida a la mesa siempre, todos los días.
So to close, I'd just like to reiterate that we think that Vermont should use it should expand its emergency Medicaid program to include immigrant workers for these treatments, because without healthy farm workers, there is no food. And I really want to emphasize that we need your support right now so that we can continue working and bringing food to your table every day. ¿Algo más, Nacho?
Oh, no, está bien. Sí, creo que está bien.
Ok, pues muchas gracias. ¿Te puedes quedar un rato por si acaso tienen preguntas para ti?
Sí.
Okay. So Will speaking again, not as an interpreter. I just asked Jose Ignacio to stay on for a little bit in case there are questions for him. But just to add a little bit onto that testimony, and what Jose Ignacio so eloquently laid out. In a public health crisis, when, as you all know, when one element of society has significant barriers to receiving medical attention, that creates a risk for the entire society. And so what we're talking about isn't just an issue of equity and fairness, it's an issue of the health and safety of the entire state. So you'll hear from Open Doors and others about the numerous barriers for immigrant workers facing access to health treatment. Even though there's access to testing, the fact that farm workers in the state understand that if I go and get tested and I test positive and I'm hospitalized, there's no guarantee that that treatment will be covered, and I'll be saddled with crushing bills and debts that I have no ability to pay. That's the situation currently, and that's been the situation before this health crisis. So people have learned the hard way that when they've had to receive medical treatment, and because there is no access to health insurance, people are saddled with these huge hospital bills that take years and years to pay off. People have learned from experience that treatment is not an accessible option. And so our real fear is that people will forgo testing, will not reach out for medical assistance, despite the excellent work that's being done by healthcare providers, particularly by the Open Doors Clinic, which is here today. There remains a large disincentive to seeking treatment. And so we think it's very important that Vermont send a clear message that treatment for COVID and related treatments will be covered by the emergency Medicaid program, and that, as Jose Ignacio said, that there not be a high barrier to proving income levels, to proving household size, in order to receive those, reimbursement for those treatments. Because it'll only take one immigrant who's hospitalized right now, or who receives treatment and is saddled with high bills and debt, for the rest of the community to get the message that, well, I better just stay home and see if I can ride this one out. So it's very important that there be full coverage for COVID, and I say related treatment, because even if the emergency Medicaid program in the state were to relax its definition of emergency treatment to say, okay, we'll cover you if you're hospitalized after a positive test, if there are related treatments that are not covered, for example, you go in and you also get a flu test, and you also get other tests and other treatments related to your symptoms, even if you end up testing negative for COVID, we don't want to see that loophole create a barrier to people looking for treatment. So anybody who's looking for testing and treatment in this moment, if they're symptomatic of COVID-19, should have full faith that regardless of immigration status, regardless of financial ability, those costs will be fully covered by the emergency Medicaid program. That's extremely important in this moment. So I'll pause there and see if there are any questions for myself or for Jose Ignacio.
Okay, muchas gracias, Jose. Tengo mucho gusto en conocerlo. We will probably have questions, and I think you did hear the testimony from Diva from Medicaid, and we will be looking for some clarification on some of the emergency treatment information. But I'm going to move. I see Representative Page has a hand up, so we'll go right to Representative Page. And then Senator Ingram.
Thank you, Senator. I realize that this is a health issue, but I would ask also, isn't this a labor issue where the farm owners, farm operators, shouldn't they bear some responsibility in the proper care of our immigration workforce? And I'll just leave it there.
I guess that is a question for you, Will, if you can respond a little bit about your understanding of what the dairy industry is doing for our workers.
Thank you, Representative, for the question. And certainly there's a vital role and a real responsibility for employers right now. There have been some dairy farms that have been reacting quite admirably, that have established very positive communication, that have put in place health measures that are recommended by the CDC. There have been many, though, that have not. Communication between farmers and farm workers has been very uneven. And as Jose Ignacio was testifying, there are these deeper structural questions that even if there's good communication and provision of PPE, if housing is overcrowded, or just by the nature of work in a milking parlor, you can't keep 6 feet distance from your coworkers as you're milking. So there are some bigger structural issues that can't be resolved by employers just in this moment. But the nature of the public health crisis goes beyond just the employer-employee relationship, because for people to get health treatment, that's something that the state has and the federal government have said that they have a responsibility for low-income people under Medicaid to provide treatment. And we're saying that workers, by dint of their immigration status, shouldn't be excluded from that commitment. So while employers certainly do have a role to play, we think Vermont also has a role, and crucially has the capacity and the resources to act in a much more comprehensive and effective fashion right now.
Thank you. Senator Ingram.
Thank you. Yeah, thank you so much, Will and Jose Ignacio, for bringing this to our attention. It's very, very important. Could you just remind us a little bit about some of the data around our migrant workers in Vermont, though how, like, for instance, how many there are throughout our dairy farms, and what generally their immigration status is?
Yeah, thank you, Senator, for the question. Estimates vary. We estimate that the immigrant dairy farm working community in Vermont is between 1,200 and 1,500 people. That's the majority of dairy workers in the state are immigrant workers, and the vast majority, I should say. And while we would never make an assumption about any specific workers' immigration status, the general trend is that workers have been denied paths towards citizenship and have been denied access to visas. There's no structural way through which somebody can come to Vermont to work on a dairy farm and obtain a visa to do so. So while some workers through various routes, and immigration law is complicated, are permanent residents or are citizens, the vast majority are not. And so the level or the rate of insurance or of insured workers among immigrant farm workers, it would be close to zero, because as you all know, for people without Social Security numbers, you cannot qualify for Medicaid, and you cannot access insurance through the health exchange, and farms do not provide employer provided coverage. So almost the entire community is uninsured.
I know that Senator Leahy's office has been, like, for instance, Senator Leahy has said many times that, you know, some of our farm workers can get temporary visas because they do seasonal work, but our dairy farm workers are in a position where they, you know, they're not like apple pickers, or, you know, they need to be, you know, the cows need to be milked all year round. So they're definitely caught in a catch-22 with the way our immigration system is currently set up. Anyway, that's just a comment, you know. that's my guy. That's what I've heard Senator Leahy's office say many times. But I was just wondering, do you have, well, maybe the Open Doors Clinic folks can tell us more about this, but it is a very dangerous situation that these workers are in. And I was just wondering if some of them have indeed tested positive, and if they're putting other others in their colleagues in danger?
Yeah, thank you for the question. And Open Doors may be able to speak to this in more detail as well. But there is at least one farm worker in Addison County who has been hospitalized, suspected or presumed with COVID symptoms. And we've been in touch with his fellow coworkers. They've received no information with their coworker hospitalized. They've had to pick up his shifts and are working both their shifts and now his as well. There's been really a lack of information and a lot of anxiety around, okay, what is this, what does this mean for us? And also what's going to happen to him once he's released from the hospital? Will he be allowed to return to the farm? Will he be covered for the time when he's been out, which should be mandated under the Families First Coronavirus Relief Act, which should include farm workers' underpaid sick leave. But we know from experience that oftentimes those sorts of labor laws and regulations are difficult to enforce on the ground.
So as a follow-up to that, and I know Representative Reed has his hand up, I'm not ignoring you. Perhaps we can get the information from the clinic, but has the Department of Health followed up with a tracing to find out contact information for the individual who is either, sounds like he's positive COVID, but has there been any tracing going on through the Department of Health on the farm to find out who's been in contact with that individual? Do you know?
We will defer to the clinic on that one.
Okay, that's a clinic question for Julia coming up, so we'll leave it there. Representative Reed.
Yes, José Ignacio, gracias por estar con nosotros hoy. Muy interesante. I had a question, I guess, about the, even if we are able to come up with a way of extending these benefits, given the natural suspicion in this community, I would think there would still be a problem getting people to come forward for care. And I guess as a related point, what degree of confidence do we have that the immigration problem is not going to crop up again or continue and just be another deterrent for people seeking healthcare?
Y Nacho, una pregunta para ti. Dado la sospecha natural que la comunidad tiene acerca de accesar las instituciones, ¿piensa que sería suficiente la acción del Estado de expandir tratamiento médico a inmigrantes? Por ejemplo, ¿seguirá el miedo entendible de acciones de inmigración y puede ser que la inmigración sigue haciendo arrestos en el Estado o vuelve a hacer arrestos en el Estado? ¿Piensa que es suficiente, que funcionaría esta acción o requiere más?
Pues nosotros también pedimos el apoyo económico porque hay personas que no están trabajando tan bien. Hay ranchos que ya cerraron. Aquí un rancho vecino, un patrón tenía 2 ranchos, entonces cerró uno y dejó abierto solamente uno y despidió a varias personas. De hecho, aquí en mi casa está viviendo una pareja que tiene más de un mes que no está trabajando. Igual no tienen ya apoyo económico, ya su dinero se les acabó. Entonces estamos, a de cuenta, comiendo de aquí todos juntos, pero pues ellos igual ya no tienen cómo igual sostener a su familia en México también, pues porque toda la familia de México igual también dependen de nosotros que estamos acá.
Well, in addition to expanding healthcare treatment, we're also asking the state to provide economic support for this community that's been excluded. There are people who aren't working right now. Farms are talking about closing. One farm in my area has closed already. This was a farmer who had 2 separate farms and he closed one and let the workers go. So in my house now, we have a couple living who's been without work for a month. and their savings have been exhausted. And so they have no money, and we're sharing our food with them. But it's not sustainable, and they without income, they can't support their family either, which has relied on their income.
Thank you. Representative Smith.
Thank you. Just a few questions. Years ago, farmers took an opportunity to take advantage of people that would work for next to nothing. I don't want to say cheap, because there's no such thing as cheap farm labor. It's quality work. But by the same token, do these farmers contribute anything at all as far as perhaps assisting in medical or paying taxes or state or federal taxes on any of these workers? And I sympathize with someone that doesn't have insurance in this COVID crisis. And I think that these either documented or undocumented migrants should receive the medical care as far as the COVID goes. But I don't know if they contribute any taxes, or do the farmers or do the workers do anything? You know what I guess it's a general question for the farmers and the workers. Who contributes to anything?
Yeah, thank you, Representative, for the question. And this is I think a question that a lot of people have, is to sort of how does this work? And our understanding is that the vast majority of farm workers are working on the books, which means that their employer is paying payroll taxes. Money is being taken out of their paychecks for federal, state taxes, Social Security, Medicare. And so workers are contributing into these systems, as are the employers. But because of their inability to file tax returns, they aren't able to expect anything back. So it's a community, and the industry is it's on the books, it's paying taxes, and so that, I think that adds a particular imperative for, as you said, the necessity for workers to be receiving health coverage in this time.
Thank you.
All right, thank you. Representative Page, is that your hand up? Okay.
Oh,
I just want to say that let's try to wind up this testimony so we can move on, and we'll hear from the folks at the clinic.
So this is just a
program. Right.
So this is just a follow-up to what Representative Smith said. You mentioned contributing. These immigrants are contributing. They're on the books for the farmers, but how can they actually contribute, or if they're here illegally and they don't have Social Security numbers? So who's checking on the farmers to make sure that they're providing, that they're paying their unemployment taxes, paying into Social Security and all this, if these immigrants do not have Social Security numbers and are here illegally?
Undocumented.
Well, undocumented.
Yeah.
Okay, thank you.
Yeah, thank you, Representative, for the question. And I think that would be a little bit outside my expertise. I'm not sure. The question sort of spans a couple of different, I think, state and federal agencies in terms of auditing for unemployment insurance, for payroll taxes. But I think the checks on Vermont farms are the same as on any other business in the state or country.
So that would extend to the Finance Committee, or maybe the Economic Development Committee, and maybe the Ag Committee. There's a whole bunch of areas that are involved in your question, Representative Page. It's a good question. All right, any other questions? One last one. Okay.
And I would just add, Senator, that there are certainly many valid concerns to have around the nature of the labor arrangements in our state's dairy industry. And this is something that Migrant Justice has been dedicated to for the past 10 years in order to ensure that the state's dairy industry can thrive while workers' rights are protected. However, given the situation that we have right now and in the midst of a public health crisis, we think that there's a need for swift and decisive action to make sure that this vulnerable population has full access to health treatment, and as Jose Ignacio so eloquently stated, so that workers can remain healthy and continue working every day to put food on our tables.
Thank you for that. The times have changed, but I guess I do have one last question for you, and I think it's a question that extends from you to the clinic folks, and that is how do you communicate information about Medicaid coverage availability, whether it's emergency testing or treatment? How do you communicate that with the migrant population that you represent?
Yeah, thank you for the question. And I'll let the clinic speak for themselves, although I know that Julia continues to do adapted farm visits in this moment. We've been in close touch with hundreds of farm workers and their families during the course of the stay-at-home order. We have suspended on-farm visits so that our staff are not vectors to propagate the spread of the virus. But through smartphones, we're able to communicate by voice, text, and video. And we are quite confident that if the state takes action, Migrant Justice, as well as other organizations, would be able to communicate quite swiftly with the community to share that information and make sure that it's accessible and comprehensive information.
Okay, thank you. Jose, muchas gracias otra vez. And Will, thank you also very much.
Senator Lyons,
Gracias igual.
yeah, Representative Reed has had his hand up for a while.
Oh, I thought I already asked him.
Yeah, I didn't take it down, sorry.
There, I knew we got you. And you
My
spoke
apologies.
eloquently in Spanish.
Sí, no.
Representative Donahue, did you have your hand up? No, okay. All right, we're good.
Ok, muchas gracias, Nacho. Te puedes quedar si quieres o si ya te tienes que ir, se acabó nuestra parte.
Ok, sí, ya voy a tener que salir igual. Pues muchas gracias a todos por darnos el espacio de aquí y pues de poder escucharnos y saber de todo lo que está pasando en los ranchos.
Thank you very much, everybody, for listening to us, for giving us the space to be here, and for hearing us speak about the situations on our state's farms.
Bueno. Okay, so we'll move on to Heidi. I don't know, Heidi Sulis and Julia Doucette, you are both here. Are you going to give individual testimony, or why don't I turn it over to you and you introduce yourselves for the record and provide your testimony as you have. I know there's something on our webpage from each of you, so we'll go from that. From one of you. Hi, it's under Heidi's name.
Oh, good morning. Thank you, Senator Lyons. I thought, my name is Heidi Sulis. I'm the executive director of the Open Door Clinic, a free clinic in Middlebury. And with me is Julia Doucette, who is our outreach nurse and nurse case manager. And I thought what might be most effective, I'm happy to provide some testimony, but I really wanted to have Julia join us this morning because her experience in working with the migrant population is deep. She's passionate. She's been leading an extensive outreach effort during COVID with some of our volunteers, and has the on-the-ground experience that I think you're all yearning to have a better understanding of. And we thought it might be most engaging to start with a patient's story this morning that I think is illustrative of the ways in which we support our patients, how we're trying to take care of our patients during this scary time, and the kind of layers of coordination that is really part of how we do business at the Open Door. So I'd like to turn it over to Julia, and then I'll back up beyond 6 feet so she can take off her mask and see you in a more human way. And then I'm happy to fill in, or we're very happy to take questions to answer what's really on your minds this morning. So I'll let Julia step in.
Good morning. Nice to see you all. So I thought it would be best if I just let you know about a patient of ours. As far as we know, it's the only patient in the state who has gone through a COVID experience. His name is Eliel, and he called us Tuesday afternoon and reported having trouble with shortness of breath and walking from his trailer to the barn without gasping for air. He felt his heart beating strongly in his chest, and he didn't have an appetite. He couldn't even hold down the black beans for breakfast. He didn't have any cough or chest pain. He didn't think he'd had a fever, but he felt like his symptoms were getting worse over the past week. He is, and I have changed facts, some certain identifying information, but at 48 years old, Eliel is a healthy, fit man who is a non-smoker and hasn't smoked since he left Mexico about 4 years ago. No hypertension or diabetes, no underlying cardiac or respiratory issues, and nothing that would put him at increased risk for COVID at all. While his main concern when he called us wasn't for COVID, he thought that he might have had cardiac issues. And regardless of his calm demeanor, he was very concerned about his symptoms. So we encouraged him to go up to the ER at Porter. He agreed, and we called ahead to give them a heads up, let them know about the triage information that we had collected, and allow them time to set up their interpreter iPad. Due to COVID restrictions, we are no longer sending live interpretation to any medical appointments. So soon after he arrived and was admitted into the ER, he crashed. His oxygen saturation, which is how much oxygen is circulating in his blood, fell to 79%. His breathing was extremely labored, and he became febrile. So they had to sedate and intubate him. They contacted UVM, and they transported him via ambulance up to the COVID intensive care unit at the UVM. 3 weeks earlier, the farm owner and his family had been vacationing in Florida and had come down with mild symptoms that they believed was just some kind of a cold. And it wasn't until one of the members of the family tested positive for COVID that they realized that that was probably what they had all been suffering from. So Eliel's up at the hospital. We got a phone call from his son, who's in California, saying, I heard my dad's hospitalized, what's going on? His dad didn't have the phone because he was intubated and was sedated so that he could remain on the ventilator. So we were able to contact the case manager and the nurse up at the hospital, provide the son's information, and help them set up the Spanish interpretation so that the doctors could communicate directly with the patient's son. Later in the day, I received a call from the farmer who had also been in touch with the hospital, and he was concerned about the 6 other workers on his farm. He has a double wide trailer for 7 people. Each of the workers has their own room, but they do share common space in the kitchens and the bathroom. I mean, the kitchen and the bathrooms. And he was not sure about what precautions, if any, he needed to take for the other 6 workers who had been exposed to this gentleman for the week prior to him being hospitalized. So I was able to go over COVID symptoms and signs with him, talk about infection control basics, how to protect himself and the workers, and I went by the next day and dropped off what we're calling COVID kits, which include thermometers and disposable thermometer covers, hand and surface sanitizer, ibuprofen, which is now deemed okay in a COVID infection, although it hadn't been prior, and 2 cloth face masks per person on the farm that one can be worn and one can be laundered. We also provided information in English for him and Spanish for the farm workers that included information about an emergency fund that Addison Allies, which is a community support group in our county, has, CDC information about how to properly clean and sanitize areas that you live with, symptoms to look out for, and what to do if you do come down with symptoms. So after 5 days of intubation and sedation, Elio was weaned off his sedatives and allowed to wake up. He was on airborne isolation, and so he woke up to fully masked, clothed people, not fully understanding what went on. Luckily for him, his attending nurse was there with an interpretation iPad to be able to explain what was going on with him. He was given back his phone and able to text with his son for the first time in 5 days. He was soon after that extubated totally and transferred into a regular medical floor where he was weaned off oxygen. And after 11 days of hospitalization, he was discharged home on Saturday, asked to take a week of taking it easy before he returned to work. So because he didn't have paid time off, he's lost 3 weeks of pay before being able to go back to work. The farmer expressed his desire to be able to afford paying his worker, but he had to pay other workers to take his place. And as you all know, the dairy industry is in a really tough financial place right now. All patients of ours, we assist through a process of patient financial assistance. So every hospital has a patient financial assistance application that takes into consideration household size and income to come up to a determination. Generally at UVM, if you are under 400% of the federal poverty level for income, you're eligible for some percentage of financial assistance. One of the issues that we come up with is that because hospital financial assistance don't take into consideration the amount of money that's being sent home for child support, if the children don't live with the worker in the US, then oftentimes their income is too high to get a true financial assistance package. Those who do, and we do have, I would say probably 60% of our workers do receive between 80 and 100% financial assistance up at the hospital. There are those that receive 40, 20, and in a few cases, 0%. Because the workers are here to support their families, the majority of the money that they're making is sent back to Mexico to support the children, their parents, their wives, their families back home. That's one of the places we would love to see change, that just like our American citizens, when money is considered for child support and spousal support, that same advantage be extended to the immigrant worker population. So in a twist, both of LEL's COVID tests came back negative. It is a COVID presumed case. Everything that they saw in all of their radiologic explorations are 100% consistent with COVID. Both tests were negative. And what that means is the Vermont Department of Health cannot get involved. They can't do contact tracing. They can't do outreach and education because there's no positive test. And so the Department of Health reached out to us and we spoke to them about what they would like done. We got back to the farmer and some of the farm workers on the farm, and we asked them to take their temperature twice a day and report any abnormal temperatures to us. Quarantine the farm. Oh, and right. And then generally when someone is given a positive diagnosis, they want everyone who's had exposure to that to be quarantined. And they asked about, can these people be quarantined in their trailer? And we said no, that if in this population and given the way that immigrant farm workers live, it's unrealistic to quarantine them as individuals. And instead, we encourage them to look at quarantining the farm as an individual so that people can still go to work who are healthy. They're working in open air or relative ventilation. It's better to have 2 guys in a barn where there's fresh air than 6 guys in a house where there's poor ventilation. Our concern was that if they were told that the other workers were told that they needed to quarantine, that they were not allowed to work, but they felt fine. The risk was that they would get up and find a place where there was work for them to do, and that would increase the spread of potential contamination. So the Vermont Department of Health, at least in our Addison County area, Addison-Rutland County area, is open to that idea of looking at kind of an alternative solution for quarantining in the population. Nobody else on that farm has gotten any symptoms. As I was surprised to hear that they felt like they didn't have information, because the ones that I've spoken to directly were given, besides the fact that confidential information on the patients, were given very specific information about how to take care of themselves and each other. So the one thing I did want to address, and I can't remember which of you asked the question, but there was a question about farm owners and how do we know that they're paying into the tax system. And I just wanted to explain that these workers who are undocumented means they don't have social security numbers. They do have individual tax ID numbers, which are ITIN numbers, and those can be used on a paycheck to get taxes taken out. One of the things that we're required to do when we apply for patient financial assistance is to get either a copy of the pay stub or a letter from the farmer listing how much they pay and taxes that are taken out. So I have seen many pay stubs from farm owners, and while I can't say that every owner across the board does this as they should, I have seen lots of pay stubs that do show that they are taking out Social Security, state and federal taxes out of their paychecks.
Thank you for that. That was very good, very helpful. See, I do have a question, and then we'll turn it over to others for questions. Unless Heidi, did you were you adding additional testimony at this point?
I guess I would just like to say that, oh, sure. That feels better to me. A couple of things, just to fan out, to give people a little bit broader perspective. Julia has presented a great kind of case study around a COVID patient, but I want to assure all of you who might not know a lot about us or how we work, that while we're not offering in-person clinics at this point in time, we are continuing to be open. We are triaging all calls that are coming in, either Julia or our program manager, Jody Brakely, with an interpreter. And so while we're not doing business as we were, I think we're doing a really good job of continuing to let our patient base know that we are here. We want to help them. Call with any questions, concerns, or a medical issue. And I think throughout the weeks since mid-March, when we've been doing this, you know, we've sent a lot of people to Express Care or the emergency room, while also trying to be sensitive to striking that balance of not overwhelming the emergency room so that they can really focus on COVID patients. So there's serious and sensitive triaging going on here. And we have a very committed staff who wants to continue to take care of our patients, and we're anxious to get up and running. We're also working under the leadership of our volunteer medical director, Lynn Larson. And then secondarily, Julia and one of our longtime registered nurse volunteers have been doing outreach to many farms in the Addison County area. I think as of today, we're up to how many farms?
32 farms, but 45 kits.
So Julia and Carol have been out to 32 farms. They've dropped off 45 kits, trying to get more kits disseminated when there are more houses on the farm. And we are doing this safely. It is kind of a drop and go, but it's all been orchestrated by Julia, who's making calls to the farmers ahead of time, making sure that they're interested in receiving these supplies. And I think overall, the farmers and farm owners have been very receptive to this and want to know how they can protect their workers. And so that's gone very, very well. And we're proud of being able to do that. And I think it also speaks to the fact that Julia's been working with, and our clinic supporting her, but working with the population for over a decade. And so there is trust, there are relationships that have been, I think, formulated and cultivated and nurtured. And so it makes working through a crisis, as difficult as it is, much easier when there are those relationships and connections already formed.
Thank you.
Yes, Julia
Something
just wants to pop in for a minute.
Okay.
Sorry, we're practicing our safe protocols here.
I just wanted to add that through this whole crisis, we have not been by ourselves. We're not in our own bubble. We are working with Migrant Justice. We're working with the Migrant Education Program, and we are a part of Bridges to Health Consortium, which is a statewide consortium run out of UVM Extension that works with immigrant farm workers throughout the state. So while we have a very committed effort that we're running here in Addison County, I just want to acknowledge that there are plenty of immigrant workers that don't live in Addison County, and a lot of dedicated people who are working together to make sure that their needs are addressed as well.
And I think Georgia, our colleague Georgia, will be addressing that this morning. Yeah.
Yes, she will. Thank you. So we have Representative Donahue and Representative Cordes, and then Senator Ingram, who would like to ask a question. I guess I'll ask you this question, but I probably can save it for when Georgia is speaking, and that is, what kind of informational packages are you sharing with folks on the farm so that they understand what they're eligible for medically? You know, so the question about, am I eligible for Medicaid treatment and so on? Those are the questions. And as that information becomes available, is that shared with individual workers? So I guess you can answer it very briefly, and then we'll go on to Representative Donahue.
So I just wanted to address the emergency Medicaid idea, because the way it has worked historically is the only way someone is eligible for emergency Medicaid is if they make the Medicaid threshold. So they need to make under 138% of the federal poverty level or less. What happens in a lot of the farm worker population, again, is they make over that threshold. So this gentleman who is in the hospital is ineligible for emergency Medicaid, even though his condition was life-threatening because he made over the Medicaid threshold, regardless of immigration status. So right now, we're not disseminating any of that information, just because it is very confusing and complicated, and there are a lot of unknowns.
Thank you. Representative Donahue.
Thank you. And obviously we have a lot of work we need to try to do in this area. This may not be so much a question as a need to hear something from the Department of Health. I was very surprised by the testimony that if it's not a confirmed positive, but presumptive, that the Department of Health can't take its role. I'm glad you're filling some of that gap, because we know it's like a 25 to 30% false negative rate. So that's a big concern if the contact tracing and all of the work that the Department of Health would be doing doesn't happen.
I might add that goes way beyond the particular group of people we're talking about today.
Yes, yes, it's a
This
very
is-
broad concern.
It's a health concern generally.
Appreciate you bringing it to our attention.
Yes. All right. Representative Cordes.
Hello, Heidi and Julia. It's very good to see you. And thank you for sharing that case study. It was very moving and very troubling. I wanted to highlight that as we're talking about COVID, the pandemic right now, and yet there are human processes that happen on an everyday basis, whether or not there is some sort of a disaster. And that, for example, is giving birth. And someone just shared a story with me that highlights the work I believe that we as policymakers have to do with our system that I think is our healthcare system that I think is inhumane and at times immoral. This story is about this actually happened, a Vermonter who was subject to the 5-year criteria and so not eligible for a hospital-free care policy. She was scheduled for a cesarean birth for medical reasons, but because it was scheduled, she did not qualify for emergency Medicaid that would be offered to her if she was beyond the 5-year bar. And I understand that's a federal criteria. So the woman was forced to choose to not show up for the scheduled cesarean and came in to the hospital in labor against medical advice, not doing the cesarean. Fortunately delivered a healthy baby. So I just put that out there because, again, I think it's critical that we have a lot of work to do to make sure that our healthcare system is universal, compassionate, humane, and moral.
Thank you for that. I think that is sort of fundamental to the work that we're doing, and we appreciate your comment. Senator Ingram.
Thank you. And thank you so much for the work that you're doing. It's so important and under very difficult circumstances. So truly thank you. I just wanted to just kind of clarify the triaging that you're doing. I mean, we tried in legislation that we did, you know, in the very first days of the crisis, we tried to expand telehealth and telemedicine, but it sounded like almost all of what you're doing is taking place over the phone. Is that true, or are you able to use telehealth, and do you have does everybody have access to broadband? I was just curious.
Thank you, Senator. That's a really good question. While the majority of what we've been doing has been over the phone, a lot of the farm workers use a Wi-Fi based app called WhatsApp. And so we do a lot of communicating through that, whether it's through video or phone calls or texting. Our medical director's in the office here every Wednesday. And so we have been scheduling telehealth visits in our office as needed on Wednesdays for non-acute issues. So I do have to say though that about a little over 50% of the patients that we see are immigrant farm workers. The other 50% are uninsured Vermonters. Our phone has been incredibly quiet since this has started. And while we are not getting the phone calls that we might get from our Vermont patients, we're still getting the same number of calls that we would have normally gotten from our Spanish speaking patients, because we are the only place for them to go in the county. We're the only place that offers that language assistance. And so we do find that it's important to include telehealth. We also receive a lot of pictures saying, look, this is my rash. And my colleague and I then triage that and turn it over to the doctor if necessary.
Okay, well, that's good to hear. Thank you.
All right, I have Representative Christensen and Representative Lippert. So Anne Marie.
Hi. So we've heard about the costs of healthcare, but Elio in the end was tested negative. So his hospitalization is not covered. It has to be only covered by him. And wouldn't that put the kibosh on anyone else coming forward if they knew they were going to have this large bill and it wasn't really COVID related?
So I think it could be argued while the tests were negative that it was a positive COVID case. And I think that if COVID treatment was covered at a state level for anybody who tested positive, or I believe the doctors would testify that it is considered a positive case. So while there's a negative test, again, all of the imaging that they did, all of the symptoms that they found, and the course of his illness replicated 100% what they're seeing in other COVID patients.
So that would be based on the physician's diagnosis as much as on a test that would have false negative.
I think it would have to be given
yeah.
the inaccuracies of the tests as they currently stand.
Right.
Thank you. And who would argue for the worker if it was not? Would that be you, Migrant Justice?
I think that's a role that we've taken in the past for sure, is as a healthcare advocate. Again, because we only cover Addison County, my colleagues at Bridges to Health would be able to take that on as well and advocate. And reaching out to Migrant Justice as well is always an option.
Thank you.
Thank you. Representative Lippert.
So first picking up, I have several questions, but first picking up on what was just being discussed, I think this is something we should clarify with the Department of Health, that in fact there is a protocol for someone whose symptoms have been clearly COVID related, that there's a protocol for physicians or medical personnel to be able to qualify that person in order for the Department of Health to do the necessary work, as well as for them to be eligible for the COVID health coverage. And I would like to just put that on the list of things that we, as our committees, follow up with the Department of Health, because I think it's an issue that has not, to be quite honest, come to our attention, at least not come to my attention previously. And I think it's critical.
So Bill, I'll step in and say that we have that opportunity on Friday when we're talking with Department of Health and some of the ethical guidelines that are being
Yes.
followed. in
Okay, good.
hospitals.
That's added to our list of
Yeah.
questions for Friday. Excellent idea.
All right.
But the thing but what I wanted to most ask you about first is to first acknowledge that the work you're doing around COVID and our immigrant farm workers is extraordinary, and thank you. But that you're actually doing this work year round and prior to COVID. And so part of what I think is important for us to understand is how you are sustained financially, or if you are sustained financially. And I know that we've had some testimony in our committees previously, but I think it's important to factor that in as we talk about the state of Vermont and its response to healthcare access, not just around COVID issues. I mean, certainly around COVID issues, but more broadly. And if you could give us a sense of how a clinic such as the Open Door Clinic is sustained financially, or what the situation is. And I know that Steve Meyer is with us as well, but I want to hear from the Open Door Clinic first.
I'd be happy to address that, Representative Lippert. First of all, the state of Vermont, you all basically vote every year on an allocation, which is now just over $1 million for the free clinic network in the state of Vermont. So there are 9 free clinics in the state of Vermont. 4 are referral only, and 5 of us actually see patients. And there's a certain algorithm, if you will, that's largely based on number of patient visits that determines kind of what piece of the pie we get. There's a certain portion of the pie that's shared equally, and then the rest is applied to this algorithm. So for the Open Door Clinic this year, we were kind of level funded for about a decade through the legislature. And then we got a tremendous boost from all of you. So just in the last couple of years, that for the ODC as an example, went from $79,000 to $84,000 a year to $116,000 a year. So that is our single largest purse of money that funds us. Beyond that, the HRSA grant is a big federal grant that Julia is involved in, which largely funds our outreach work. And we've been doing that work for about 10 years. So that's another significant purse of money. This year it's $45,000. Just to give you a scope, our entire operating budget at the ODC this year is $429,000. And we employ 8 part-time people, just to kind of lay the groundwork.
Yes,
so we have the state of Vermont, we have some federal funding. Our local United Way has been very generous and supportive over many years. That's an application to which I apply. And then, as I often say to our donors and our friends, it's an ever-changing constellation of funding sources that we're currently teasing out and applying for. So we have, on any given year, I think this year I'm operating from 9 different grants, some small, some very sizable. And then we do an annual appeal every year. And one of the things I've worked really hard on since I've been here is kind of cultivating our local donor base and raising awareness about who we are. And that has been successful. We have a number of community members who really stand behind us. But it's, so on a good day, I would say that in a cheerful voice, and on a not so good day for Heidi Sulis, I worry all the time about, you know, ongoing funding, or if we don't get this, then this. And so, you know, it's that fine. It's just something to tread, but it is our reality. And we've been around for 20 years. So when I get really down in the dumps, I think, you know, history shows that we're still here, we're still needed, and we always make it, and we've grown. So that's how that works.
Thank you. I think it's important for us to understand that you exist in that manner, and that you, I mean, the good news is that you've been there for 20 years. The bad news is that it's been necessary for you to be there for 20 years and still be there. But I think it's important for us as legislators and legislators responsible for healthcare in the state to understand that when we talk about access to Medicaid for patients, and that's often a source of revenue, that we're talking about other appropriations that we make that actually support access to healthcare outside of the traditional system. And I think it's also, I'm just going to say, I think it's also important. I think what you indicated, at least the Open Door Clinic, is that about 50% of your clientele, the patients that you work with, are from the farm worker community. Is that fair to say? Or something akin to that? I don't want to.
It's fair to say. It is fair to say, and you did hear that correctly. And it kind of depends how you look at our stats. So if you look at our total number of unduplicated patients, I would say it's more like a third and 2/3. So a third undocumented workers, 2/3 Vermonters. But on any given clinic night, so the people who are attending our clinics comprise probably upwards of 50% are undocumented workers. And I also need to correct myself. We've been here almost 30 years.
30 years.
But your point is well taken, Senator. And I would also just like to say, because sometimes people still don't get it, I'm sure you do. But when I'm explaining our situation in the community, people will say, but you take Medicaid, right? And it's like, no, we don't take any insurance. We're not reimbursed by any third-party payers. Our services are free of charge, and we look at all of these ways to cobble together the money to fund our services.
Just one quick.
Yes, Julia.
I just wanted to add one quick thing, which is during this crisis, at a national level, people are looking at the uninsured and saying, well, they can go to an FQHC and the federally qualified health care is the way that the majority of healthcare is provided to people who don't have insurance. And I think just to put a plug in there that for those 50% of patients that we see who have language needs, there's, while it's federally mandated to have language access at these FQHCs, the front desk don't know how to work the language access. They don't know how to work the phone interpretation. And there's all steps of access along the way that require a language that provide barriers every step of the way for these workers to access care through an FQHC.
Thank you. And by broadening the conversation, I don't mean to take the attention away from the immediacy of the COVID situation, and our immigrant farm workers are essential workers, but I think it's important for us to have the broad picture as well. Thank you.
Thank you for that, Bill. I think the testimony that we've heard in the past, in particular from Steve Meyer, has helped us understand some of the nuance of funding. So key to understand. Steve, I'm going to jump over you, and unless you have something that you would like to add within just a couple of minutes. Okay, we're fine then. Good, thank you. And thanks for being here with us. I'm going to move to the Bridge program. Georgia Maharis is here to talk about it as she's Vice President of Policy and Programs at Bi-State Primary Care, but here particularly to talk about the Bridge program. So Georgia, Bridges to Health, I should say it correctly.
Thank you. And I'm putting my video back on. My internet's been a little unstable, so I was having bad sound quality. So I'm hoping, fingers crossed, internet stays okay so I can keep the video. Thank you for your time. For the record, my name is Georgia Maharis. I'm from Bi-State Primary Care Association. And I'm here to talk with you about the Bridges to Health program. This was referenced just a few minutes ago by my colleagues at the Open Door Clinic. And I did provide a background 2-page document that you should all have access to that just gives a little bit more information about this program. I think the key things I would highlight about this program are the folks working on this around the state have been doing this for over a decade. So to the extent that we have such a committed team around the state and resources available and those trusted relationships that Heidi referenced, that's because we have folks who've been working really hard for a very long time to support this population. The folks who are working together on Bridges to Health Bi-State, we have a role as leading the work. But really the lion's share of it is the UVM Extension Center puts together a lot of materials, communications, guiding documents. Open Door Clinic, other clinics around the state, federally qualified health centers, Planned Parenthood hospitals. So really a lot of coordination working around the state with the various entities. I think a key point that I want to underscore that was demonstrated by what Heidi and Julia said is that working with this population, I think, goes beyond the term cultural competency. It really gets to a level of specialized assistance that is really, you need a special person, you need certain materials, you need a lot of hands-on time, hands-on virtually or in person, and really an acknowledgement that there's a level of fear with many of these individuals. There's potentially language barriers, cultural barriers, financial barriers, transportation barriers, and it just requires a lot more thoughtfulness and work to provide the appropriate level of support. So it is very resource intensive, which Open Door Clinic demonstrated. I would also note that the folks at the UVM Extension, as part of the COVID-19 response, they did reach out to all the farms around the state and said, here's some materials for you. Please, we're reminding you, farm owners, that we are here, that Bridges to Health is here, that all of these resources are available to you. So, hopefully there was some good communication and information. And to your question about the information that's shared, I'm happy to get samples of that if the committees would like. But I do know that there was educational information that went out. And additionally, I wanted to highlight the recent focus of the Bridges to Health program. So as I said, they've been working together for over a decade. And the most recent 3 years has focused more on mental health and access to those types of services. Because it's growing more and more important to make sure that is addressed as well. And in particular, some of the materials related to COVID-19 highlighted self-care and managing stress and anxiety in these times where there's a heightened level of stress and anxiety in this population and generally. So I just wanted to note that there was again, some work in the pipeline on that and was augmented during this particular time with COVID-19. I also want to highlight just a question around the funding, since you did talk about that. The Bridges to Health program is funded by a federal Office of Rural Health Policy grant that comes to the state of Vermont. And it has been through several successive rounds of funding from ORHP, which has been great for our state. That funding is set to expire in April of 2021. The Bridges for Health core team is already looking to see what we can do in the future to make sure these programs are sustained, expanded, and we don't lose this key resource into the state. But there's always a question mark when funding for a program ends. So didn't want to ignore that as something that is in the works. And then finally, I wanted to talk a little bit about, dive into a little bit more of this language access that the Open Door Clinic did highlight. And yes, access to translation services is significant and challenging around this state. I would note that with the virtual world of telemedicine, it is a little bit harder at times to get some of those translation services in. For some entities, I know that some languages are easy to bring in because there's more people who have the ability to do that translation. For more unique languages that are more specialized to a subset of our population, it is a bit harder to get those in because then you're connecting multiple people into the telehealth visit through different connections. So I just wanted to acknowledge that there's a particular dynamic with converting virtually to making sure that there's sufficient translation. And I would also offer that our Burlington Health Center has historically had a very robust set of translation services. They've got the Nepalese population, et cetera. And to my understanding, they're able to maintain that level of translation for them. So, kind of figuring out those solutions as we go. But I want to make sure that was acknowledged. And then the final piece is we've talked a little bit, or you've all talked a little bit about the impact to the patient and the financial burden that they're experiencing. And at least from where the FQHCs and the free and referral clinics, who are also a member of Bi-State and Planned Parenthood sit, they take their mission very seriously about taking any patient regardless of ability to pay. And so, there's easier ways and harder ways, right? Because if it's a virtual world, sometimes you have to put those pieces in. But we are doing everything we can to remove those financial barriers as to the greatest extent we can. So I just wanted to acknowledge that is a very real concern we have for our patients. We are seeing more uninsured, to your earlier point about people being uninsured. And we also are seeing more people where it's really hard right now. And so as my last statement, I would actually ask something of you, because last time I was in front of you all, you said, let us know if you need anything. So what I'm hoping that you can all help with is really getting the message out that primary care is open. Our doors are open. We are here for patients. We're taking emergency dental. We really are growing increasingly concerned that people will, with well intentions, not seek the care that they need. And so to any extent, or to the extent that you can help get that message out that our doors are open virtually, And of course, urgent care and emergency rooms are also available for care. We would greatly appreciate it because we're just, my doctors are getting worried about making sure that folks are getting the services they need. They're doing well checks and they're checking in on folks with outreach, but every little bit helps. Thank you.
All right, thank you. Thank you for that overview. That's helpful. And we have heard about concerns about people not seeking primary care and preventive care, including dentistries. It's important for us to get that word out. We agree. I do have a question, and that is, as you provided information out to the farms, or the Extension Service has done that, have you also provided that information to the clinics as well as to Migrant Justice? So everybody's on the same page, I guess.
So we have provided to the clinics. I will apologize that I am not sure if we have provided it to Migrant Justice, but we're happy to. Will, if you don't have it, just let me know and we will get that over to you. My apologies for that, not knowing that answer. But yeah, we definitely send it out to the clinics. And I think this is actually something else that the Bridges to Health program has done generally, which is get policies, procedures, guidelines, all sorts of information out around the state just to help our clinicians around the state understand what resources are available. So they've pushed a lot more out. There've been a lot more board approved documents in this area as we're trying to just keep spreading the message and the importance of making sure that you're caring for this population, which is uniquely situated in a special way.
That's great. I do think Bridges to Health, meaning bridges to everywhere, which is connecting people and places, very important. Questions from the committee for Georgia? I don't see any hands up except Representative Lipper. Is your hand up?
It is. Yes,
All
it is.
right.
Yeah. Georgia, can you help me make sure I understand in terms of Bridges to Health, which is where you get support from the Extension Service? Am I correct in understanding? Is that where the grant comes through, or so that's just a minor technical question I just would like to understand. But is Bridges to Health exclusively or primarily focused on health outreach to the farm community, immigrant farm community? Am I correct in understanding that? And if I'm not, would you correct me on that? And
sure.
Then if it is the case, can you help me understand again the reach, the number of dairy farm workers that are immigrant farm workers across the state that, as you are aware of it? I mean, we asked Will Lembeck the similar question. I'm just trying to get a sense of what others' perspective is as well. Not questioning what Will said, but just trying to get another perspective.
Sure. So to your first,
across the state as well.
Yeah. To your first question, the funding comes from the federal government to by state, actually, and then we have financial arrangements with UVM Extension, Open Door Clinic, and then other arrangements happen beyond that. So that's kind of the dollar flow. In terms of the second question, yes, you are correct. And in terms of the number of farm workers, the information that I have indicates that we are touching an estimated 1,000 farm workers through this program annually, and that we're providing services directly to about 49%. So that gets us in the 2,000 to 3,000 range. I'm a little hesitant to offer numbers because I feel like any number I give you will be underrepresentative. Just going back to some of the earlier conversation as part of this hearing, and the fluidity of some of the individuals and the concerns that they have, in particular those who are closer to the border. with Canada and concerns that they have. So those are my estimates, but my numbers, I would say, are a little underrepresentative.
So I understand that, and I understand the difficulty not wanting to have individual farms or workers targeted because they live in fear of immigration issues. But at the same time, it does seem to me that someone in the state of Vermont, through the Agency Agriculture or others, should have some good sense of what's happening on our dairy farms. And I had intended and didn't, because of other pressing issues, didn't reach out to the Agency Agriculture or the Secretary to possibly be with us today, but I might like to do that in the future to actually have their perspective as well.
I have
and does the extension service, extension is often, or is it does extension put any state dollars into this program? Or is it strictly
I
federal?
do not believe that, but let me just confirm that fact.
Okay, great, thank you.
Bill, your comment about the Agency of Agriculture is a good one. I had a note written earlier when the conversation went to farm quarantine to reach out through the Department of Health and the Agency of Agriculture to sort of find out what their determination is about a farm quarantine policy. And there are other questions that we might have for them.
Yeah, Secretary Tebbets was, Anson Tebbets was being interviewed by Jane Lindholm on Vermont Edition several weeks ago. I tried to locate that before, I didn't have time to review it. And I think it'd be important for us at some point to engage the Secretary of Agriculture or the Agency of Agriculture around these issues.
Well, it sounds like a quadruple committee meeting.
Could be, yeah.
It could be. All right. Any other questions? Yes, Heidi, you have a question or a comment, but please go ahead. Better unmute. Yep.
So in terms of numbers, I just wanted to give a little perspective. We, on any given year, see between 320 and 385 immigrant farm workers in Addison County. We estimate that there are probably about 500 or so in our county, and our county is the highest concentration of farm workers in the state. So just to give, you figure Franklin County is a little behind that. And so I concur with Will in the working number that we use is between 1,000 and 1,200.
Thank you. Any other questions? This has been really very informative and helpful. And I want to thank each one of you who has testified. I think the clinic, Migrant Justice, Bridges to Health, it's been extremely useful to us. And we've identified some, obviously there are a lot of issues embedded in this, but we've identified some that we might be able to follow up on. The question of eligibility is always a tough one when we're talking about Medicaid funding, but it certainly seems as if when someone is being treated for COVID in the emergency, that when every insurance carrier is paying for this right now, that it doesn't seem fair to have someone left out of that payment stream. So that's one area that we're going to have to look at very closely. Bill, did you want to make any final comments?
Yes, there are a number of issues, I think, as you've identified some of them, that where I think follow-up is in order. I'm also struck by what we've appeared to have learned today, that when an immigrant farm worker seeks financial assistance in our hospital system, that they in fact may be inappropriately made ineligible because of issues of not recognize the funds that are being provided for childcare, et cetera, and the resulting ineligibility for full but for full financial assistance. And I think that's something which I'd be interested in us pursuing with either the Vermont Hospital Association or understand whether there's something that we should at some point engage with.
Yeah, it does. It also sounds like something that the Human Services Committee on your side of the fence might be interested in looking at as well. So another.
I think it's it's directly a hospital issue, and so I think our committee should.
Okay.
But
we're
either
good
of
with
us,
that.
I'm fine. With
I'm
that.
happy either way.
Yeah, but I want to thank everyone who testified today, because I think it's part of what our goal was, to highlight issues that we didn't fully understand or where we need to take some initiatives. And there's certainly plenty that's been raised here. And I know that some other members are looking at some other initiatives along the lines that go beyond the healthcare world. So I think we'll hear more about that at some point.
Yeah, good. Thank you. Senator Cummings, I see you're waving.
Just a word of caution, and I'll leave it to the folks that work in the field. But if we focus too much attention, I'm a little nervous about giving out numbers of migrant workers in this state. ICE is still alive and well.
Yes,
and
that's right.
As bad as it might be here, it's a lot worse in cages on the border. And
I completely agree with you,
I think we
Senator.
need to be very careful.
I think you're absolutely right, Senator. And
that's been in my mind all morning. So,
okay.
Thank you, Senator Cummings. Any other questions? I see Senator McCormick. You're muted.
Oops.
Thank you. Sorry. Yeah, this is more of a statement than a question, but I would invite response or comment. It seems to me that the quarantining issue should not be that hard to deal with. Seven people in a trailer during an epidemic is just ridiculous. If nothing else, porta potties so that they're not all sharing the same bathroom. That would not be hard to do. Similarly, FEMA during hurricanes puts out these trailers. We should be able to have additional housing. That's just one example. By the way, I don't know if everyone's seen Jeb Spalding has withdrawn his suggestion about closing the state colleges. That came in on the upper part of the screen. Okay, that's all. I just wanted to say, I think we as far as aiding ICE and catching these people, I think what we just need is no questions asked care, rather than saying we're going to give care to the migrants. Just no questions asked care.
well, there was in the resolution that the House passed, actually in the first day of the pandemic, along when we passed our bill, we also passed a resolution calling on the federal government to declare safe healthcare zones, which we understand has been done in the past and has not been done during this period.
Yeah.
Not that provides, absolute security by any means, but it certainly would be in addition to what, and that had the unanimous support of the House.
Okay, I see Representative China's hand is up, and Will, you wanted to make a comment on that last point. So why don't we go there first with Will, and then we have Representative China and Senator Ingram.
Yeah, thank you very much, Senator, for recognizing me, and Senator McCormick for the comment. Wholeheartedly agree in terms of sort of by focusing on the issue, unwittingly bringing ICE's focus onto it. They're way ahead of us on this one. Secret's out, so it certainly shouldn't be. And I know nobody's suggesting this, but shouldn't be an impediment to really forthrightly and honestly dealing with the issue of undocumented workers on farms. ICE is very much aware of the situation, and I think the real issue for the state is, as Senator McCormick said, giving aid without implicating people by asking burdensome and intrusive questions about status, or asking people to demonstrate proof of ineligibility for Medicaid, something like that. And then thank you very much for raising the question about housing as well. That to us is one of the most acute issues. We can provide as much information as we want about 6 feet and coughing into your elbow, but if you have to share a bed with somebody and split shifts and sleep shifts, no amount of healthcare information is going to do you any good.
Thank you. Representative China, Senator Ingram, and then Representative Cordes.
Thank you. So thanks to everyone for your testimony today. I heard a few people mention during their testimony that that there was stress associated with the COVID pandemic connected to health issues and finances. And in general, so what I'm wondering is what mental health resources are available to our migrant workers right now. The second wave of casualties from the pandemic is going to be the mental health impact on people. And it sounds like that our migrant workers are already working under difficult conditions with the economy the way that it was. And it sounds like that's worse now. So I'm just curious, like considering all that, what mental health resources are available?
Georgia.
Hi, Representative Chino. That's a great question. The UVM Extension and Bridges to Health folks have put together self-care packets that have some mental health resources. So I'm happy to circle back and get that to these committees so you actually have the resources in hand for you to look at.
That would be very helpful. Thank you. Senator Ingram.
Thank you. Yeah, I just wanted to comment on what we were talking about with regard to immigration and I mean, there is going to continue to be a tension between a state like ours and the federal government, but I don't think that should let us, that should stop us from doing, what we think is the right thing. I mean, you may have seen also that President Trump has said he's going to be signing an executive order prohibiting immigration into our country today, as well. So, I mean, this is just going to be an ongoing thing, but we need to do the right. We need to do the right thing here in Vermont, regardless of what ICE is up to.
Thank you. Representative Cordes, and then Heidi. Heidi, did you want to respond to Senator Ingram's comment?
Or Representative China's question?
Julia wanted to respond to Representative China's question about mental health resources.
Thank you.
Go ahead. Thank you, Bill. Yeah, go ahead.
So I just wanted to comment that the HRSA grant that Heidi mentioned that we are on a consortium with Bridges to Health, the last 3 years we've been funded specifically to address mental health issues. So it's a very timely pandemic in that we are especially funded to try and address the mental health of workers. And as such, we have seen an increase in this time in the telehealth visits that we've done. Our doctor has seen 4 people for mental health related issues, some related to increased alcohol use, some really related to increased anxiety, and a couple of depression issues. And 2 of those people we've referred to our mental health counselor who's working, well, we have a few, but there's one particular one who's covering the crisis, and she's working from her house in Williston. And she has provided telehealth counseling visits for 2 of those patients. So we are still open for business, as well as I know my colleagues in Bridges to Health have been doing increased screening and increased offerings. There's an online little yoga class that people can call into through WhatsApp. And there's other resources. We have a Nuestra Bienestar, which is our Facebook page where a lot of the resources we put are specifically related to mindfulness, relaxation, and addressing increased stress.
Terrific. Will, you want to comment?
Yeah, just to briefly add that in addition to the treatment options that Bridges and Open Doors just spoke about, I mean, thank you, Brian, for the question, because mental health is a huge concern. Suicide suicide attempts are not uncommon among farm workers. And so in addition to treatment, it's really, I think, let's not overlook the role of policy in addressing the social determinants around incidences of mental health and things like providing access to healthcare treatment, providing financial economic assistance in a time of crisis are the types of things that the state can do through policy to reduce the feelings of isolation and persecution that lead to depression, anxiety, and other mental health issues.
Thank you. Representative Cordes, you had a question.
A comment.
Okay.
Some of you in this meeting are aware that there's a movement in the House, and I think there's similar work being done in the Senate to have a task force. There are chairs and members of committees of jurisdiction who are ready and feel it's very important to address the issues of our immigrant community in Vermont, especially around the issue of this pandemic. So I'm just, because we're all here together, asking our committee leadership in the House to help me communicate with our leadership to see if we can make this happen. I know leadership's incredibly busy, but I think a task force would be very helpful.
All right, thank you for that.
Yeah, can I say thank you, Mari? I didn't want to get out ahead of you. You have informed me of that, but that's what I was part alluding to earlier when I said there were other folks trying to put together resources, and I am completely in support of the initiative.
So yes, and you know, it would be great to have your group bring recommendations to the committee as we're looking at budget adjustment or other appropriations. And also obviously you'll be putting together recommendations for various agencies, but we're happy to facilitate that communication maybe as a joint committees. Be good. All right, any other questions? Comments? I'm seeing no hands. I thank you. This has been a very effective day, an important day for us and our continuing work together in House and Senate. I appreciate everything that you have each brought to the meeting. So thank you all for being here. And I include in that folks who are testifying, folks and our committees. So thank you. Bill.
Senator Lyons, I'd like to again acknowledge that I think our committees are modeling for maybe hopefully for some of our other colleagues the ability to work collaboratively in hearing witnesses that inform both our committees simultaneously, both for the efficient use of witness time. And I think it's frankly, I'll say it's enriching to be able to have this kind of dialogue between our committees directly. So I want to salute you, Senator Lyons, and everyone else in us being able to do this as we determine it's appropriate going ahead. And again, we will be doing some of this again on Friday.
We will.
We have a joint hearing scheduled, I think Friday 9:30 to noon. Can I just take a minute, Senator Lyons, to say that in a communication from the Speaker of the House, because we in the House are now moving into floor sessions as well, scheduled floor sessions. And we have scheduled witnesses on Friday jointly with the Senate Health and Welfare from 9:30 to noon, but there is a House floor session that has now been scheduled for 11 a.m. I was contacted by the Speaker late last night, and I indicated that I believed we could in fact have House members be ready to able to go at 11 or shortly before 11. In reviewing what the testimony is, I think we as the House will need to end our participation on Friday morning in order to be ready to participate in another floor House session.
I think the testimony will probably be complete.
Yeah, I think
by 11.
as I looked at it,
I don't think there's any need for you to be stressed.
Yeah, I just wanted to
time.
acknowledge when others see the conflict on the schedule that they not be wondering how we're going to address it. I think we'll be able to accommodate it well.
What I will do is what I'm going to ask my committee to do is at 11 o'clock, we can have some time for committee discussion and what we'll be looking at going forward. So
maybe we could ask Demis to put adjournment at 10:45 or 10:50, maybe 10:50 for the House on our agenda. So that
sure.
it's clear
That's
that
fine.
we need to go to our House session.
That's fine.
Great.
Okay, we'll take care of that. And in the tradition of Senate Health and Welfare, and now it sounds like House Healthcare, we have finished early. So thank you all. Buenos dias. Buena suerte. And we'll see you on Friday. Oh,
Okay.
look, wait, Lucy. Lucy, did you have your hand up?
I was waving goodbye to everyone.
Okay.
Thanks.
Goodbye.
Bye.
Hasta luego.
Thank you very much.
Thank
Take
you,
care.
Will.
Nelly and Demis for
Vaya con
facilitating
Dios.
this session.